Good afternoon, everyone, and thank you for joining us. My name is Lakeisha Montgomery. I am the Director of Professional Education and Training for the Southern New Jersey Perinatal Cooperative, which is presenting today's webinar entitled Teaching New Parents to Speak Up About Post-Birth Warning Signs. This meeting is now being recorded and will be shared on SNJPC's website for future viewing. Before we begin, I'd just like to go over some information and just some housekeeping. So first, we have our disclosures. The Planning Committee and content reviewers have no conflict of interest to disclose. Disclosure forms are required and they are reviewed for issues. There will be no discussion of off-label use of FDA-approved products. There's no commercial support for this program. Speakers are required to present balanced and unbiased presentations, and this presentation has been reviewed and any bias has been eliminated. Our speaker is an AWHONN consultant, and the activities in this presentation were supported by funding from Merck through its Merck for Mothers campaign. And the process for receiving contact hours, to receive contact hours for this program, the registrant, you must sign on to the webinar, attend the entire presentation, and complete and submit an online evaluation. A certificate of completion will be emailed within 1 week of the program. This program has been awarded 1 contact hour. No partial credit will be given. And this is our accreditation statement. And these are our learning outcomes here. Just a couple more things. So during the presentation, please feel free to put any questions or comments in the chat box. We will hold time for Q&A at the end of the presentation. And now I'd like to welcome our presenter, our speaker today, Dr. Patricia Suplee. Dr. Patricia Suplee is the Director of Professional Education and Research at the Central Jersey Family Health Consortium. She is also an Associate Professor at Rutgers University School of Nursing in Camden. As a seasoned researcher, scholar, and educator, Dr. Suplee's career has focused on improving maternal child health outcomes. Currently, her work focuses on improving maternal outcomes, translating evidence into clinical practice, especially during the postpartum period. Her collaborative work on AWHONN's Empowering Women to Obtain Needed Care project led to the development of post-birth educational tools that have received national attention. These tools are being incorporated into postpartum discharge teaching throughout the US and have been cited as exemplar by the CDC, HRSA, and the Joint Commission. Due to her expertise, Dr. Suplee was appointed to an interdisciplinary national committee that developed 3 AIMS patient safety bundles that are currently used as best postpartum care practice models. She was also a member of the U.S. Department of Human Health and Services Office of Minority Health Think Cultural Health team to advise the development of an e-learning program for physicians, nurses, and healthcare providers about culturally and linguistically appropriate services in maternal health care. She is chair of New Jersey AWHONN and is a member of the New Jersey Maternal Mortality Review Team that analyzes cases, identifies gaps in care, and makes recommendations to decrease maternal mortality rates. Dr. Suplee publishes and presents nationally, is a reviewer of several journals, and has mentored numerous faculty, colleagues, clinicians, and students over the last 3 decades. At this time, I'll turn it over to you, Dr. Suplee. Thank you very much for presenting it today. It is a pleasure to have you present this valuable information to us. So thank you.
Thank you, Lakeisha, for the introduction, and thank you, Southern New Jersey Perinatal Cooperative, for hosting this presentation. Again, the focus is really going to be about teaching new parents to speak up about post-birth warning signs. And what is driving this presentation is really how do we best improve care to the people that we serve. Specific outcomes include describing the current rates, leading causes, disparities, and timing of maternal mortality in the United States. Examine the role of the nurse, doula, community health worker, and home visitor in providing comprehensive education, support, and empowering postpartum families. And integrate A1's post-birth warning signs into your interactions with parents before and after birth. So the first thing I want to talk about is really what is driving some of this information we have when we look at how can we best serve women. In 2019, the statistic rose to 754 women who died during pregnancy or after related to giving birth or complications of birth. And this was 2019 data reported in 2021. And what you can see with data is we tend to be at least a year or two behind in reporting by the time you get the statistics. And what's more important in the maternity world is where and how and who we get the statistics from. So you're going to see that there are several times when the statistics don't seem to match, or that different titles are used when we're expressing numbers or ratios. And I am going to go through that with you. So for an overview, we're going to jump into trends, causes, timing, and disparities. So here's a graph for you on pregnancy-related mortality. Now, again, I want to go through a definition for you. Maternal mortality ratio is the estimate of the number of maternal deaths to live births, meaning a ratio. So again, 1 in 50, 2 in 100, etc. Pregnancy-related death is the death of a woman while pregnant or within 1 year of giving birth from any cause related to or aggravated by the pregnancy or its management, but not from an accidental or incidental cause. So for example, a pregnancy-related death may be the woman who develops a deep vein thrombosis. So again, that deep vein thrombosis is clearly related to her pregnancy. And then we have a title called pregnancy-associated death, and it's the death of a woman anytime during pregnancy or up to 1 year post-delivery. So again, it's the same time frame. However, these deaths can be completely unrelated to her pregnancy. For example, maybe a woman died in a car accident 6 months after she gave birth. Well, technically, that's still counted as a pregnancy-associated death. So what I want to encourage you to do is, as you read through statistics and you hear statistics, you have to really look at where the statistics are coming from as well as their true definition. So on this graph here, you're going to see that we're talking about pregnancy-related mortality ratios. So what you have is from 2005 and now up to 2019, which is the last year that's been reported. We have been fairly flat. Now, again, if I was to put 1987 here, you would see like a gradual increase and then a flattening. And the flattening doesn't mean that it's good, because obviously we're still staying in a higher rate. Here you have 14 deaths per 100,000 live births in 2005. And here in 2019, we're at 20 deaths per 100,000. So you have to look at that with relationship to the numbers you were dealing with. So between 2018, which is at 17.4 per 100,000 deaths, we've actually jumped to 20.1. And I have to tell you, don't be surprised if we get the 22 back and it's even higher, especially with the COVID numbers that are going to be embedded into these statistics. The other thing you need to understand is that review committees will take all of these cases in their states, and majority of states are doing this, and more states have been doing it longer than others. But we review the case and we actually say, well, was it pregnancy related or was it pregnancy associated? And sometimes the statistics that come out, for example, these 2019 cases, may not have even been reviewed yet by the case teams in each state. So again, look at the statistics for what they are, but also know in the United States, we do have a higher mortality rate for mothers than other countries. We can also not forget that this number is still not acceptable. Maternal mortality is a complex problem ranging from how data is reported, how social determinants of health are captured in reporting, and due to the racial gaps that exist, how we can address implicit bias and structural racism that contributes to these outcomes. We can do better, and we must do better for new moms and their families. When we look at the actual reason for why women are dying, there is a myriad of reasons. However, we can put them into a graph related to hierarchy. So here's a graph showing the deaths between 2011 and 2016, and these were reported by the CDC in 2020. So again, you can see how the research is back a few years, but you do see that the highest rates are for cardiovascular conditions, medical non-cardiovascular conditions. They may be things like kidney disease, diabetes, infection and sepsis, hemorrhage, and you can see down the line what the leading causes are. But what I do want you to also see are what highlighted in pink: cardiovascular conditions, cardiomyopathy, and hypertensive disorders are our cardiovascular disease take up about 34% of all maternal deaths. Now, for those of you working in the hospital, you may say, well, I don't really see that many cardiac cases. And those in the community may say the same thing. However, we do know that cardiac does drive this. And we also know from what we've learned physiologically is that the body has a tremendous input into making that transition between cardiac load after a woman delivers. And some women transition well and others not so well. We also see that cardiovascular disease can extend out for a year postpartum, but most likely often occurs by 6 months postpartum if it's going to occur at all. The timing of the pregnancy deaths is also important. The majority of them do occur in the postpartum period, and that's this green area. 31% in the antepartum period and about 17% on the delivery day. So when you think about it, when most people think about, wow, a mom died, they tend to go right to the hospital with, oh my goodness, they must have had a really bad birth. But the reality is they die after they get home, which is really important for us as care providers to understand that we have a big job to do between the transition from the hospital to the home or wherever the mom is going to live. All pregnant women are at risk for developing a postpartum complication due to the physiologic changes that occur with pregnancy. Although the overall risk is small, it is still important for women to hear about it. So if we know the causes and know the timing, what can we do as providers to improve outcomes? Can we break it down even more to what we should expect each week? Can we look at, if we know the common causes, how we can address them? And if so, it brings us to how do we educate better? So knowing the actual timing can be helpful when creating interventions and providing preventative measures. Nurses do provide the bulk of discharge education, have been doing so for years. But what, when, and how we teach can influence maternity care. So again, let's focus on this report that was, again, looking at deaths between 2011 and 2015, and also 2013 and 2017. During pregnancy, the leading complications were non-cardiovascular conditions, cardiovascular conditions, and infection. Delivery day, they seem to change a little bit. This is where you're more at risk for hemorrhage, amniotic fluidism, correct? Now we go to the first week home, hemorrhage, hypertensive disorders, and infection. We go up to about the 6-week checkup here, infection, cardiovascular, cerebrovascular accidents, and then 43 days to 365 days. This is where we get into the cardiomyopathy sometimes and the additional cardiovascular conditions and then non-cardio. So depending on where you are actually interacting with the patient, these are only the 3 most common causes during that time frame. It doesn't mean that there aren't other causes that, cause death, but these are the 3 most common ones. So the other thing we really have to look at is we've looked at ratios, timing, and causes, but another clear statistic that is vital to this discussion is the racial and ethnic gap that exists in our country. As you can see from this figure by the CDC, Black women are at least 2 to 3 times more likely to die than their white counterparts. Okay, so again, 37.1, 14.1. Again, that's a double, a little over a double there. And then you have Hispanic women here, who again are less than non-Hispanic white women. It is important for nurses to be aware of this statistic and get involved in their states to identify what can be done to improve these rates. New Jersey has a Nurture New Jersey campaign led by Tammy Murphy, who has included racial disparities in her maternity care plan as a top priority. Now, this does not mean necessarily that we have to focus on one population or another. However, it is important to know that more Black women are dying compared to other Black women when we look at ratios. This is also a breakdown of racial ethnic disparities in pregnancy-related deaths from 2007 to 2016. And again, a nice infographic by the CDC. Now, if you follow me up here to the first graph, you're going to see that it's broken down into pregnancy-related mortality ratio, okay? And then you have 2007, 2008, and then you get a double years until we get to 2015, 2016. And if you look at it at first glance, you're going to say, wow, it really hasn't changed much. Like there hasn't been a drastic increase or one over the other. It has stayed pretty steady. Well, that in and of itself is a problem because right here, this lavender bar is American Indian Alaskan Native, and this purple bar are Black women. So you can clearly see that Black women have a much higher risk of maternal mortality. And then coming in second is really our American Indian Alaskan Native populations. When we look at disparities across the nation, we do see that state pregnancy-related mortality ratios were placed equally into 3 groups, high, medium, and low, and the PMR was further calculated by race. Even in states with the lowest chances of pregnancy-related mortality, they still had a higher rate of Black women dying. And then when we look at age, we will see that unfortunately, those over 40 have a much higher increase in risk, especially Black women over the age of 40. And here's where it gets very fascinating when we talk about education, because what you're going to see here is that for Black women with at least a college degree, they were still 5 times as high as white women with a similar education to die. So it's not always about education. And this is where implicit bias and racism, structural racism and individual racism does play a role. So let's get into a little bit about postpartum hospital readmissions. You know, many of you probably don't even know how they are calculated or how your hospital collects them. But I do want to talk to you a little bit about the research. In 2016, Clapp and colleagues reviewed cases of readmissions in the first 6 weeks in California, Florida, and New York over an 8-year time span. They found that 2.16% of all deliveries were readmitted. And you think, well, that kind of sounds low until I give you the number. 115,000 women were readmitted for a postpartum complication. That really sounds drastic there. The most common indication for readmission was infection, followed by hypertension issues, and then psychiatric illnesses. Most of these readmissions occurred on average 7 days after delivery. So again, the woman hasn't even been home a week and she's being readmitted to the hospital. In another study by Nassib and colleagues in 2018, they looked at readmission rates as a quality indicator. This was done at one hospital where readmissions were reviewed over a 17-month period of time. And again, they had a 1.55% readmission rate. Hypertensive disorders were responsible for 42% of those hospital readmissions, followed by wound complications at 18%. In 2020, Wen and colleagues published a study investigating fragmentation of care. They used a national database of readmissions between 2010 and 2014. They found that 15% of readmissions occurred in hospitals that were not the original birthing hospital. And these researchers found that those women admitted were more at risk for severe maternal morbidity and increased length of stay. So again, think about that. You're talking about the woman delivers in one hospital and shows up at a non-birthing hospital with a complication of giving birth. So again, if that hospital doesn't practice OB, they're probably not up on the latest evidence-based practice that we have when caring for women in the postpartum period. So once again, I would have to ask you, are you aware of the institution's rate that you practice with or that you're associated with when you provide care to women outside of the hospital? How would you go about finding out this information? And in fact, do you know your hospital's cesarean section rate, which can contribute to maternal morbidity? Now, the hospital C-section rates can be found on the Department of Health website. They are public knowledge, so I would say to you, go ahead and look at those rates because they are there. But what I also want to hear you or start thinking about is, what is your role here in trying to think about prevention? Because prevention is what we're always trying to target. So if I say to you, one of the leading things that we see in the first 7 days home are readmission for hypertension, you might start thinking, well, preeclampsia, gestational hypertension, what did we miss here before she left the hospital? So again, is there something that can be changed in your teaching, or were all the kind of boxes checked off before she even left? When we look at best practices in postpartum education, we really do know a lot. And again, we can see here through multiple topics, but yet it's hard to rank what is most important. You know, I think if we were to survey nurses, they would probably come up with 3 different things if I asked what were your 3 leading indicators. And the same thing out in the community. If I were to ask the community health workers or home visitors, what are the 3 things you have to touch on? We may have different experiences based on what we bring to the table. However, all of these are vital that we touch on, but we really do also need to talk about the potential for that woman to develop a complication. And there are some people that feel that, wow, that's really scary to tell them about that stuff. But the bottom line is, if they don't know enough about it, they're not going to know what to do if they experience it. So it really is vital that we squeeze in the post-birth warning signs here in pink into the circle of all the other things that you're going to be teaching. So what do we have to do to make sure new mothers receive all the education they need to care for themselves and their infants, but not make it about the infant? Maternal self-care is important, and women need to hear from you. She needs to hear that she too is important during this transition. All mothers should have a voice in their postpartum plan. She should be able to identify her support system, her postpartum care team, including her healthcare providers and community providers. Remember to provide women with information that is literacy level appropriate and language appropriate. And it is also important to provide education in front of a support person. Asking a woman where she is going post-discharge is important, as many women may not be going home, but may be going to a family member's home or to a shelter. And I did find this in one research I did in Camden, New Jersey, that we had some women who actually, when we talked to them, they talked about, moving around with regards to not being in one place for the first 6 to 8 weeks of their postpartum. They talked about going into shelters. They talked about being at friends' homes, parents' homes, significant others' homes. So again, we really have to touch on the experience for them and where they're headed. And finally, the importance of returning to her postpartum follow-up appointment should be stressed. People may say to you, when am I going to be seen? Some hospitals will schedule that appointment. Others have the person call themselves. But either way, it's really vital for us to stress the importance of going back for that postpartum care. New moms also need to learn about potential warning signs. This information is not to scare them, nor do they need to hear a lengthy discussion of mortality. In fact, I don't use the word mortality and morbidity when I teach, but it is our role to empower them with tools, in this case, education, which includes what to look for and what to report to their provider so they can be seen in a timely fashion. I want to stress here the importance of giving women a voice in their care. So let me give you a little background on how A1's post-birth warning signs tool were born. First, it started off as a quality improvement project funded by Merck for Mothers to A1. Deborah Bingham and I led the project, and we started with nurses. We wanted to hear directly from them what was being taught, how it was taught, who it was taught to, and any information that could assist us with our project. We interviewed nurses from 6 hospitals in 2 states. What we found most often that the focus of the teaching was usually on the baby, and that information and level of information varied not only between hospitals, but within the same staff. There were several aha moments for staff with regards to their different teaching methods and what information they provided on the same topic. Just as one example, when I asked, what do you tell women about bleeding? I heard they should call their provider for any excessive bleeding. If they had a lot of bleeding, they should go to the ER. If they passed a clot larger than an orange, a golf ball, a pear, a plum, but not a Costco plum, or had a handful of clots, they should notify their provider. So what did this all mean? And more importantly, what did it mean to the new mom? What does the word excessive mean? How do you quantify that? What is a lot? An orange? Think of how confusing this can be to someone who does not measure QBL on a daily basis or is familiar with how much blood a peri-pad can actually hold. What we ultimately realized is that before we focused on messages to new moms, we had to focus on consistency of education provided by the nurses. So this is what's rich about doing research, is sometimes you go in with one idea, and as you collect data, you kind of go down the road of changing that idea. After coming up with our A1's tool and having a panel of maternal experts provide their comments, we then went back to the hospitals to see what the nurses thought. We received an overall positive response, and they were very satisfied with using the tool with their new mothers. Nurses now use the tool when they teach women about what to assess for, some using paper handouts, others build it into their EMR. And we also started and continue to hear stories about women who have returned to their provider or to the emergency room with the tool in hand, reporting something that they learned about and were encouraged to tell someone. There is a clear example on A1's site, and that's AWHONN. It's a video recording of a patient who actually went home, had an uncomplicated birth, and she just was struggling a little bit with getting back to herself. She had a little bit of shortness of breath, just didn't feel right. Her mom kept saying, oh, just rest, and this is what it's like to have a new baby. And she kept saying, you know what, there's something not right. I don't know what it is, but there's something not right. She took out the post-birth warning sign handout, and she said, you know what, Mom, I'm going in. And her mom said, no, I don't think you need to go in. It's just, give it another day. And she said, no, I'm going in. And she went in, she got checked, and she did end up having some clots in her lungs. And she was then treated for those. So we tend to always tell the birthing person, never poo-poo anything you're feeling. If you're feeling something that you don't think is right, tell someone, tell your significant other, tell a friend, call your physician. I mean, tell someone that will at least give you support and push you to use your voice if you're not currently using it. And again, the major take-home points here was that we have to teach what to look for and what it could mean, and then what to do with the information. We don't want to use it as a checkoff list because, again, that becomes an empty piece of paper. But we also want to reinforce it at multiple touch points. So let's take a look at this tool that's on your left here. It is being used around the country by nurses and patients, and I believe every hospital in New Jersey is now utilizing it. It can be found on AWHONN's website, and you can also contact AWHONN to use within your organizations. It has been translated into 4 different languages, and they continue to post more all the time. These are also available in posters in English and Spanish in New Jersey. They've just been distributed to all pediatric providers throughout the state because they too are a touch point for women to review this information. Women do take their children in for their pediatric visits. So again, another touch point. So I want to break this down a little bit more for you so you can understand what goes on physiologically and what might be happening pathologically to understand risk factors and what's to teach. You will see we did this handout with a lot of information from collaborators and also consultants. So the first thing you're going to notice is that there's a statement, most women who give birth recover without problems, but any woman can have complications after giving birth. Learning to recognize these post-birth warning signs and knowing what to do can save your life. Now, however you want to open this dialogue with the person is fine. What you don't want to do is get them anxious about this piece of paper, because if we can empower through education, the woman is going to feel better about reporting these signs and symptoms to her provider. So you're going to see in the red box, call 911 if you have, and it spells out POST for post, and call your healthcare provider in the yellow, spells out BIRTH for birth. And you can see on here what each letter stands for. The other thing you're seeing here is that it says, trust your instincts. Always get medical care if you are not feeling well or have questions or concerns. Tell your 911 or healthcare provider, I gave birth on, or I gave birth a month ago, I gave birth 2 weeks ago, and I am having chest pain, okay? Get the patients, get the birthing people used to using those phrases. The next box is a little more in-depth, higher level information. And we put that on there so people would know how to speak the lingo if they heard it. So it is there for them as well as a review. The other thing we like is that the patient can put on their healthcare provider right here, the phone number, and the hospital closest to the person in case they cannot do them themselves and somebody else needs to help them. So here we go. Let's start with P is pain in the chest, think cardiac. Normally, cardiac output and stroke volume increase by 60 to 70% after delivery. Within 1 hour postpartum, cardiac output returns to pre-labor levels. Cardiac output returns to the person's normal level within 6 to 8 weeks. So here's what I was saying by some people transition without any problem, and other folks are going to have a little bit of a problem with that cardiac output transition. What we see is that the blood pressure may rise slightly, then return to pre-pregnant value in a few days. The pulse is slightly decreased in the first 2 weeks, and then normal heart rate goes back to about a 50 to 90 beats per minute. But it really is important also to ask the patient, do you know what your normal heart rate is? So you do have some comparison. And then trending changes should be observed and reported. We do know that cardiovascular disease is the leading cause of maternal mortality, and that tied back to those original slides. And many times vital signs aren't the first clue. they are the first clue to cardiovascular changes that require further assessment. But unfortunately, that might not be occurring in the hospital. It actually may be occurring when they are home. We like to tell the patients that chest pain is not normal, okay? If a woman is in the postpartum period and she's having chest pain, that is not normal. It can be related to angina or possibly a pulmonary embolism. And also cardiomyopathy, which is another definition of a cardiac condition in and of itself, is a new onset heart failure, whereas patients may complain of shortness of breath, coughing, and may even have swollen ankles. Risk factors include cardiac conditions, having an arrhythmia, use of cocaine, valvular disease, family history of these types of diseases, and then also obesity and smoking. So what I usually say is if you have shortness of breath, like you can't catch your breath, difficulty breathing, heart palpitations like your heart is racing, or you have chest pain and pressure, you want to call 911 or go to the hospital right away. O is for obstructive breathing. Post-birth, there is an immediate decrease in intra-abdominal pressure that occurs, and the respiratory system returns to the pre-pregnancy state. The normal respiratory postpartum rate is between 16 to 24, and the normal oxygenation saturation is between 95 and 100. If a woman complains about shortness of breath, a full respiratory exam is warranted. You want to observe her breathing, listen to her lungs in all fields, not just the bases. Assess a pulse ox. Ask her if she is having pain on inspiration or expiration. Again, on when she breathes in or when she breathes out. If she calls in complaining of shortness of breath post-discharge, have her go to the ER for follow-up. She could be experiencing a pulmonary embolism and she really needs to be evaluated. The most common symptom of a pulmonary embolism are tachypnea, okay, or rapid breathing, and tachycardia, rapid heart rate. Risk factors, prolonged bed rest, C-section is a risk factor, or surgeries, and then hypercoagulopathies of pregnancy are also risk factors. So what we teach, if you have shortness of breath at rest, chest pain that worsens with coughing, changes in level of consciousness, call 911 or go to the hospital right away. Now, one thing that I have to add to the O is problems with breathing may be related to COVID. And before, obviously, this wasn't part of our post-birth warning signs, but we do instruct patients again about the signs and symptoms of COVID. And again, it's, the coughing, the difficulty breathing, the possible shortness of breath, the possible chest discomfort, fever, chills, feeling malaise. We do still go over all those COVID signs and symptoms, but they actually might also fit into this respiratory category. S is for seizures. It is not normal for women to experience a seizure after she delivers. They can be a sign of eclampsia, or a person may have a seizure disorder such as epilepsy. Risk factors include a history of preeclampsia and seizure disorders. If a person calls and says his or her partner is having a seizure, 911 should be called immediately. They should stay with the person, position the person to the side to prevent aspiration or them swallowing any of their secretions, and you focus on the safety to prevent injury. So make sure the person is glided into a position, usually laying down and to the side. Oops, I shouldn't have gone to that one yet. Let me go back. The other one is T, rounding up the post, thoughts of hurting yourself or others. Although this category is not on the top of the list for pregnancy-related death, we felt that it was important to add to the warning sign sheet due to the potential for tragic outcomes. It is not normal for a woman to want to hurt herself after giving birth. Post-birth blues is very common, and major depressive disorders with peripartum onset is the official diagnosis for PPD. Several factors can contribute to postpartum psychiatric disorders, such as psychosocial factors, neuroimmune factors, hormonal alterations, genetics, and sleep alterations. Risk factors here: previous history of postpartum mood disorders in past pregnancies, history of depression, psychiatric illnesses, and sometimes we see low socioeconomic or socio issues will fall into this, stressful life events that can occur, etc. What we say: if you have thoughts of hurting yourself or others, call 911 or go to the hospital. So now we're on to birth, the term birth. And here we have bleeding, and bleeding or hemorrhage. Normal blood loss is about 500 cc's for a vaginal delivery and about 1,000 cc's for a C-section. It is important to measure QBL to aid in this assessment. Excessive bleeding needs to be assessed and treated quickly. Bleeding is most often related to uterine atony, meaning that it doesn't tone up, it doesn't firm up, but can be related to lacerations or retained placenta, DIC, or infection. Risk factors include multiparity, or again, a woman who has had multiple pregnancies, overuse of Pitocin in labor, and a history of coagulopathies. So what do we teach here? Assess for the amount of blood loss, but you describe the amount that is concerning. So we usually say if you saturate one pad an hour, a saturated pad is about 30 cc's of blood. Passing a clot larger than an egg. Now, before I mentioned that people described it as a golf ball, an orange, a plum, an apple, a grapefruit, a dime, a quarter. We wanted to think universal, what everybody would know, and that's why we chose an egg. An egg is actually a size, again, 2 to 3 inches in length. And again, we use that as a cutoff there. Ask about feeling lightheaded or dizzy. Again, this can also go into the drawer with bleeding and hemorrhage. And you want to call your provider. Have the woman lay down, put her feet up, feel for her uterus, make sure it's nice and firm, and obviously call the provider. I is incision that is not healing. Now, this can be with a cesarean section or a vaginal delivery. Because again, a woman can have a repair of the episiotomy or tears. So what should you assess? Redness, swelling, if it looks black and blue, or what we call ecchymosis, edema, discharge. That discharge can be different colors, and approximation, meaning that the incision is staying together in like a similar line. Risk factors: obesity, infection, and then what we teach. Assess the wound daily for signs and symptoms of infection, such as drainage. So again, you want to have them describe the color of the drainage and where it's coming from. Redness or swelling, or separation of the incision, almost like the incision is opening up. We also will have patients take pictures, and they can show them to the provider if they're going for an online visit. But we also sometimes will say to take a picture for women who can't necessarily see what they're looking at. Maybe if a woman is a little bit heavier and they have, they need to lift up their belly to actually see their incision, maybe by taking a picture, they'd be able to see the incision. You also want to keep that incision nice and dry and intact. The same thing can be done for the vaginal area. You know, she can take a picture and then you can see what that looks like. R is for red or swollen leg, and this is tying us together with deep vein thrombosis. There is an increase in fibrinogen and clotting factors during pregnancy, as well as an increase in venous stasis, meaning that the blood isn't moving as quickly as it usually did. It may lead to an increase in thrombus formation or a clot. So women are at risk for deep vein thrombosis, which could potentially lead to a pulmonary embolism because that clot eventually releases and travels to the lung. Risk factor: having more than one baby, obesity, assisted vaginal birth, maybe meaning that you had vaginal delivery with forceps or vacuum. Immobility, C-section, and advanced maternal age is a risk factor. What we teach: we assess for redness, tenderness, swelling, and warmth of a leg, usually around the calf, so it's behind the leg. Most times we see it in one leg. We don't see it in both legs. So that's another sign that it may be a DVT. But you definitely want to call the provider. T is for temperature above 100.4. This is a good cutoff for us to use. However, women may be dehydrated and they may show signs of infection that way. But we do use 100.4. So you would like your women to go home with a thermometer or to have a thermometer at home. It could be related to wound infections following C-sections, mastitis, again, inflammation, infection of the breasts, urinary tract infections, or an infection of the actual uterus called endometritis. Other risk factors, having your bag of water being broken for a long time, having a C-section, vaginal repairs, and also obesity. We tell all women that a temperature greater than 100.4 needs to be reported to her provider. And here we are with H is headache. Headache is not a normal finding in the postpartum period. Now that doesn't mean that a woman can't have a headache, but we're looking at the headache that really doesn't go away if you use over-the-counter medications. It can be related to hypertensive disorders or high blood pressure, especially preeclampsia, or it can even be a migraine headache. It is important for nurses to know that women can develop preeclampsia or eclampsia in the postpartum period. And that also goes back to when I was talking about when people get rehospitalized. What did I say? One of the leading risk factors where it was hypertension and infection were the two leading causes of why women get rehospitalized. So think about that. If you're doing all this education, they may be more well-informed to look for these things in the postpartum period. The severity of the headache needs to be assessed, which can be done using a rating scale. Mild headaches may be the result of dehydration or stress. However, it is very concerning when a woman complains about a severe headache or states, "It is the worst headache of my life." That is a big indicator there because I can't tell you how many women will actually say that phrase. Risk factor, history of preeclampsia or hypertension or migraines. And again, assess those headaches, the location, the duration, the intensity. And again, she needs to be told to call her provider very quickly. There are other comorbidities that obviously didn't make this list, but it's not that they're not important. And one of them is mental health, and I'll talk about mental health in a little bit, drug use, and other medical conditions. So you still want to do this assessment, especially if the individual has any of these documented. You really need to address them before she goes home. Now, birthing people with opioid use disorder, we do see that there are risks. Again, they're there for you, psychosocial, economic, social support, and also neonatal abstinence syndrome. If we find that we're seeing some information from the neonate that may want to take us back to the mother, that's going to be important. Women should be advised not to discontinue meds, and they want to educate on discharge with an RX for naloxone. So again, when people are discharged with opioids, you also want them discharged with naloxone. Advise about the risk for relapse in the postpartum period. It's going to be important. Contraception education. Women who tend to use more drugs as far as drug use, they may not use the best effective method for birth control, and they may not return for birth control at the postpartum visit. So it really is important that you talk about these things. And then wraparound services. What's the plan of safe care for this person? Identify and connect parents to services in the vicinity of where they are going post-hospital stay, and then arrange for an early touch base. And I have to really say to you, it's really important to make sure that you're connecting the person to a place near them. So I have a little video to play, and this is just an example of a nurse teaching a new mom about post-birth warning signs.
Hi, Jocelyn. I'd like to teach you about some signs you should be aware of that might mean you are having a problem after giving birth. Is this a good time for you?
Yeah, sure. The baby's getting circumcised, so is in the nursery.
Would you mind turning off the TV? Are there any other signs that might mean you are bleeding too much that you might experience?
Oh yeah, if I feel
can't tell
lightheaded
if
or
the
dizzy.
video's working.
Wonderful.
It's not working for
Just
me.
remember that if you are feeling lightheaded or dizzy, you should lay down and call for help. Will you have anyone staying with you after you are discharged?
Yes, my boyfriend. We live together.
Good. All new moms need support when they get home. The next topic is shortness of breath. Most women do not have difficulty breathing after they deliver. However, women who have difficulty breathing may be having an issue with their heart or lungs. Have you ever experienced difficulty breathing?
Just when I exercise, I sometimes feel my heart racing and I have to breathe heavier.
Yes, that is what happens when we
I
exercise.
don't
Our
think
heart
the
rate
video
goes
is
up
working,
and our
but
breathing
I'm in the
can be a
middle
bit
of
more
thunderstorm
labored
where
to
I
get more
am, so I
oxygen
don't
to
know
our
if there's some
lungs.
interference going
You
on.
shouldn't
So
feel
I'm just gonna
shortness
move
of breath
forward,
or like you can't catch your
with
breath
the
just by doing
presentation.
normal activity.
There are several touch points that we encourage education to go on. So again, you're going to see that there are so many different touch points we want to use to talk about the post-birth warning signs. And the more education we can get out there, the better it's going to be overall. When we look at contributing factors to maternal mortality, we do know that there are patient provider, facility, system, and community, and the family gets tied to the patient. We have to look at preventability very carefully because we have to look at, could a death have been prevented had we done something differently? Or if we had looked at this mom a little bit differently, or if we had revealed some information differently. So again, I think preventability is very important as we look at how we can improve care to our moms, not only in the hospital, but also in our community. So what's your role in improving these outcomes? Start with you. Do a self-awareness check, equity check, social influences and competencies. Make sure you're staying current on your education. So again, there's plenty of competencies out there. A lot of the consortiums, all three, North, South, and Central, offer a lot of educational resources. You want to integrate evidence-based practice resources into your practice and elevate communication by using cuss words. And for you, some of you that are unfamiliar with cuss, this is like kind of coming off the SPAR report, where we used to report that way and we still do. But this was developed by the Agency for Healthcare Research and Quality, and it stands for Concerned Uncomfortable Safety. So here's an example. I'm concerned about our patient, Mrs. Schalt. Her blood pressure has not decreased since our last conversation. She is also experiencing a frontal headache. I'm uncomfortable with her clinical picture at this time. Can you come evaluate her? I believe this is a safety issue. The other thing is we want to look at how we teach parents during every encounter. Many of us will use the teach back method, which is a method that has been designed that you want the patient to explain in their own words what they need to know or do in a caring way. So again, that video, unfortunately, you probably couldn't hear it, was me using the teach back method, teaching post-birth warning signs. So some of the phrases though you can use when you teach is, so I know that I have explained this properly. Can you tell me in your own words about, etc.? What will you tell your family about your high blood pressure? Using your own words, tell me how you will assess if you're bleeding too much. We talked about a lot of things today, so I want to make sure I explain them well. Tell me what you will do at home if. So again, some nice phrases to keep the dialogue going, but it allows the patient to provide you back some information on what they think you taught them. And this way, if it's not correct, you can then reteach. You want to provide consistent messages to all women and their partners, but individualized care. You want to stop, look, and listen. And a lot of this comes down to pausing and stop thinking about all the other things you're supposed to be doing and stop, listen to what the patient has to say very carefully because we are missing some things. The other thing is to empower. And I have to say, empowerment can be a process and an outcome. You can give people the tools and the skills to become more empowered to speak up, but you can't just say, I'm going to empower a person. They need to feel empowered. And then you want to reassess when your role ends. You want to make sure the person going home is well connected to all the services that that family is going to need. You want to speak your mind, even if your voice shakes. And this is one of the quotes I love from Ruth Bader Ginsburg, and that there's a lot of fear that people have when they're getting ready to speak up. And they doubt it. They wonder if they should. They don't know if they're going to look stupid. They don't know if they're going to be reprimanded. But what I have to say to you is, it's more important to speak up for your patients. And as you do it more and more, your voice is going to shake less and less. Here are some examples of some places you can find some good evidence-based information for you. And these are all links. Again, these are the safety bundles. There's a postpartum care bundle. There's also cardiac bundles, hypertensive bundles. You're going to see that there's A1 educational webinars. There's the ACOG toolkit. And then there's the Institute for Perinatal Quality Improvement, which you'll also find resources. But what I want to say to you to end this presentation is that I hope it did provide you with information to take back to your organizations and to your colleagues. And I encourage you all to take a small step in doing something. Volunteer to be a part of a committee that reviews your policies and procedures. Post current articles on a bulletin to share with others. Start an Article of the Month club. Choose articles that can enhance care or services. Do a mini presentation on your institution's leading causes of postpartum hospitalizations. Obviously integrate the post-birth warning signs, but don't only do it in your postpartum unit, but make sure your clinics have them and they're facilitating their use. Get involved in department collaborative teams, and the list goes on, but do something, just something. Your voice and your actions are powerful. We need you, nurses, community workers, doulas, home health workers. We need you all on deck to tackle maternal morbidity and mortality in every institution and every community setting. And thank you so much for your time today.
Thank you, Dr. Suplee. Your research and this presentation has been so vital in decreasing those adverse maternal outcomes. So I know it saved many lives, and I'm sure will continue to save lives. So at this time, does anyone have any questions for Dr. Suplee? I don't see any in the chat box, but if you do, please feel free. Okay. So someone wants to know, will the presentation be made available?
Yes, it will. It will be available on the consortium website that people can watch it again. Yes.
Yes, and it will be uploaded to the SNJPC website as well. Any other questions? Comment? Okay, thank you. Carly says thank you. She just wants to thank you for putting this presentation together today. Thank you, Carly. We're happy that you all could join us. Any other questions? I have a question. How can non-hospital providers like pediatricians address post-birth?
Oh, sure. So like I said in the beginning, we just mailed out, I think, over 1,400 posters to all pediatric providers in the state of New Jersey. I received a grant from the Tara Hansen Foundation to do that. And basically what we would like is that these posters are hanging in the office. So birthing people can read those posters while they're in the waiting rooms or in their other rooms. But also it's to address, to the mom, how are you feeling? And is there anything going on with you? They could easily adapt to, reviewing the post-birth warning signs with them. And I don't think, people might necessarily do that at first because, again, they're not used to asking the mom all those questions. But they could easily say, you know, have you had any of these issues since you've been home, and let them read off of the post-birth warning sign education. So they easily can take this on. But again, right now, we're just hoping to get the information into the offices so it can act as another touch point where the new mom might actually be reading this information again.
Thank you, Dr. Suplee. I don't see any more questions. I just wanted to restate the criteria to receive nursing contact hours, just because I received a question. Just for anyone who's missed it, after the presentation, you will receive an email link to complete the evaluation. And after that, you will receive your certificate of completion within 1 week. And unless there are any more questions, this will now conclude our presentation. Thank you for joining us, and we hope to see you at future SNJPC offerings. Thank you for joining us.